Assalamu alaikum and very good evening. I welcome Dr. Mohammad Arifur Rahman. Welcome you all to this Cathlab National Technician course. We are very delighted to have our panelists and lots of members, active participation already on the dais. At the beginning, I would like to request our Professor Abdul Wadud sir to say a few words and to start the program. Wadud sir. Wadud sir.
Hey, hello.
Sir.
Good evening, everybody.
Yes, good evening, sir.
Thanks to our learned faculty that they are here. And today we are going to have the third installment of the our Cathlab Technician Refreshers course, I would say. And that will be for them, by them. And our very intelligent, very articulate technical experts, technicians, they are from 3 countries, from Bangladesh, from India, and also from Nepal. They'll be joining us together and they'll be delivering the lectures, sharing their practical experiences and the whole thing from their own perspective, from a technician's perspective. And I hope this will be very much helpful for both all the technicians who will be attending, also the young cardiologist, because these people are doing these Cathlab procedures each and every day with so many operators. So their experience, we should count on them. We should get ourselves enriched from their knowledge. And we should use that knowledge to our own advantage for the benefit of the patients. Thank you everybody again. And I hope we'll be enjoying the session together.
Thank you, sir. Thanks a lot for valuable comments. Now, I'd like to say a few words to Dr. Mohsin Ahmed as well, sir, course director, IPDI. Mohsin, sir.
Thank you, Dr. Arif. At first, I thank our speaker, Mr. Kaushik Datta. He is estate manager of Cathlab, CK Birla Group of Hospitals in Calcutta. And then another speaker from Nepal, Mrs. Shanta Singh Thakuri, Cathlab nurse, Shahid Gangalal National Heart Center, Kathmundu, Nepal. Also our 2 speakers, Mr. Nazrul Islam, also Farhad. They are all, the person are very known to us. And our learned faculties here. I see Professor Supriya Rahman, Professor Afzalur Rahman sir, Professor Atahari sir, Dr. Arun Maski from Nepal, also Dr. Khanduka Jaman. I think another panelist also joined. Thanks all our participants, different institute Cathlab nurse and technicians. And also I will thank Incepta Pharmaceuticals. They're doing a lot for last 8 months corona pandemic. And also Boston Scientific. They sponsor this program. And I think everybody are waiting for this very nice session today. Thank you, Arif. You will continue.
Thank you, sir. Thank you, sir, for your comments. Now, I'd like to request Professor Afzalur Rahman, sir, to say a few words. Professor Afzalur Rahman, sir.
Thank you very much. Thank you for inviting me. This is really a great session, I think so. Technician and nurses is the I would always say that, who is your best friend? I says that the anesthetist. Who is the next best friend? I say that the technician. And who is the next best friend? Then I should say to the surgeon, even in my NICU life. So technician is very important part and person. And they can rescue us during that devastating situation. So this kind of the refreshment course is very important, and to upgrade their knowledges and share their experiences. And thank you for arranging such kind of exciting session.
Thank you, sir. Thank you for your valuable comments. In the meantime, our very respected panelists are already joined, and lots of participants are already waiting for the present lectures from our valuable speakers. In this situation, I'd like to request Mr. Kaushik Datta, Assistant Manager Cathlab, DK Birla Group of Hospital, India, to deliver his speech. Mr. Kaushik Datta, please share your slide.
And good evening, everybody. First of all, I will say in this situation to having this and participating in this webinar is very appreciating and is a very good effort because there are so many new Cathlab has come in Bangladesh, and as well as other portion of the India, so many new Cathlab is coming and new generation of technicians as well as the junior consultant also is coming for doing the procedure. So it's very important to share our knowledge, and is because there are in my topic is hemodynamic monitoring. So there are some another topic also is there, so that we can share our knowledge among us, so that in future if there is any problem we can solve out the situation and we can help our operator. So I am going directly to my presentation. So that is actually this is hemodynamic monitoring. Actually, whenever the operator is doing procedure, at that time the operator is very much need to patient side, means he is very much concentrated about his work. So in that time, other portion means the hemodynamic portion, if we see it properly and inform him properly, then that will be very much helpful for him. So for that, we are there and we are helping them in this matter. So what is hemodynamic? Hemodynamic means hemo means blood and dynamic means flow. So what is the definition? Means hemodynamic monitoring definition is the measuring and monitoring the factors that influence the force and flow of the blood. Means how the blood is flowing inside our heart. In the end of the session, means end of the my presentation, I will show the one video how the blood is flowing inside the heart and how we have measured that one. So what is the purpose of hemodynamic monitoring? Means is a diagnosing, monitoring and managing critically ill patient. Means sometimes some patients are very much critically ill. So in that cases, the hemodynamic means how the patient's LV and diastolic pressure is there, how the patient PCWP pressure is. So that is very important for the patient for treating the concern, for treating the disease. So objectives, purpose of hemodynamic monitoring, indication of hemodynamic monitoring, biological sensors and monitoring, pulse oximetry, which is very important in this situation, in means COVID situation, is very important. So whenever we are feeling the less oxygen, our means SpO2 will be coming down. Automated blood pressure device, arterial, central venous pressure, pulmonary artery catheters, and cardiac output, as well as the oxygen delivery variables. So cardiac output also is a very important thing in a hemodynamic monitoring. So what is cardiac output? Cardiac output is a product of heart rate and stroke volume, and it's measured in the liters per minute. Heart rate is most commonly defined as the number of times the heart beats in 1 minute. And stroke volume is the volume of blood ejected during ventricular contraction or for each stroke of the heart. So whenever the heart is contracting, so in that time, how much blood is going out of the ventricle? So that is the stroke volume of the heart. So parameters means cardiac output, how we can measure by what is the equation. Cardiac output equation is heart rate into stroke volume divided by 1000. The cardiac output normal range is 4 to 8 liters per minute. The unit of that cardiac output is liters per minute. Then cardiac index is cardiac output divided by body surface area. So that is normal range is 2.5 to 4 liters per minute per meter squared. What is stroke volume? Stroke volume measuring cardiac output divided by heart rate into 1000. Normally, the normal range of the stroke volume is 60 to 100 ml per beat. And stroke volume index, that is CI, means cardiac index divided by heart rate into 1000. The normal range of the cardiac stroke volume index is 33 to 47 ml per meter square per beat. Means each and every beat, this will be the stroke volume index. The next is the hemodynamic monitoring. Is referred the measurements of the pressure, flow and oxygenation of blood within the cardiovascular system. Means sometimes we are having some, we are taking some samples from different chambers of the heart. Sometimes some patients are having some congenital disease, means like ASD, VSD, PDA. So in that cases, we are calculating the shunt, means always shunt means the reverse flow. The flow is coming from higher pressure side to lower pressure side. If the patient is having ASD, then blood will come from left atria to the right atria, because the left atrial pressure is little bit more than the right atria pressure. Same as if there is some ventricular septal defect is there, then left sided pressure is always higher than the right sided pressure. So the blood flow, if the patient is having VSD, the blood flow will from left ventricle to the right ventricle. So in that cases, we are calculating the shunt, means whether the patient is operable, is the surgeons also dependent from our value, means whether the patient is operable or unoperable after calculating the shunt. The purpose of monitoring: early detection, identification, and treatment of life-threatening condition, such as heart failure and cardiac tamponade. Evaluate the patient immediate response, treatment such as drugs and mechanical support. Evaluate the effectiveness of the cardiovascular function, such as cardiac output and index, which I told previously that how we can measure the cardiac output and cardiac index also. Indication: all types of shock, means there are 3 or 4 times shocks are there: cardiogenic shock, distributive shock, then the obstructive shock, and hypovolemic shock. Cardiogenic shock, we all know. Cardiogenic shock, if a patient is having severe heart rate, the heart rate is more than 100 and the blood pressure is less than 100. Systolic blood pressure is less than 100. And sometimes some patient is coming with this and with a severe heart rate and low blood pressure, means systolic blood pressure less than 100. And the patient is having triple vessel disease, or maybe 2 vessel disease, or maybe single vessel disease, and is coming in a acute myocardial infarction. So to manage the cardiogenic shock, whenever we are taking this patient in our cath lab, the rules is not a infarct related artery. If a patient is having triple vessel coronary artery disease, in a patient who is cardiogenic shock, immediately we have to open whatever we can, means in cath lab, how much we can do, we have to open the vessel. Means if the sometimes in a primary PTCA we are doing the infarct related artery only, but in a cardiogenic shock patient is coming into the cath lab, we have to give the benefit as much as we can. So if a patient is having triple vessel disease, then we have to put stent, or we have to open the vessel as much as we can. Then distributive shock, that is something different, that is not in managing in cath lab. Obstructive shock also is not, is a obstructive shock like a septic shock, and that is also not managing into the cath lab. Sometimes in a hypovolemic shock also happening in the cardiac catheterization lab. Hypovolemic lab means, hypovolemic shock means the patients who are having some low fluid. Actually, hypovolemic also is not happening in the cath lab. If a patient is having loose stool or sometimes like that, then patient will be having some hypovolemic shock. Anaphylactic shock also happen in the cardiac catheterization lab. So anaphylactic means patient will have, maybe it's a reaction, means dye related. Whenever we are injecting, maybe patient go to the anaphylactic shock because of the allergic reaction. So that is very important to see that anaphylactic shock, whether, I mean, after, whenever we are starting the procedure, whenever we are injecting the contrast media, that time always we have to remember, we have to tell the doctor, please give 2-3 ml contrast media, and then wait 2-3 minutes whether you have seen there is any reaction is happening or not. So that is very important, because all time the consultant cannot concentrate with this. We are the technician and we are the nurses, and we are the nurses who are assisting the procedure. They can remember the consultant. They said these are the things, you can check it first. Types of hemodynamic monitoring: non-invasive is the clinical assessment, and NBP, non-invasive blood pressure measurement, direct measurement of the arterial pressure, invasive hemodynamic monitoring. Continuous versus intermittent, invasive versus non-invasive, never therapeutic but maybe diagnostic. Non-invasive hemodynamic monitoring, non-invasive BP temperature, skin test, heart rate, pulses, capillary refill, mental status, urine output, molting, and pulse oximetry. These are all non-invasive. Pulse oximetry, estimated oxyhemoglobin as SpO2. The target SpO2 will be more than 92%. Heart rate display should be same as pulse rate captured by the probe. Goals. So what is the goals? Means confirm diagnosis, initiative treatment, monitor for improvement, or worsening to the heart condition. Then in the transducer, means how we are getting the pressure into our cath lab. So there is a transducer. What transducer does, it's the mechanical energy is converting to the electrical energy, so that we can see the pressure tracing in our monitor. So actually through the transducer, the pressure is coming into the monitor. So the position of the transducer will be 3 inches below to the mid chest, means phlebocystic level below 3 inches. And each and every inches 2+ mmHg pressure will be increasing into the fluid. So that diaphragm will be delivered to the transducer, that is 2 mm/Hg to the true intravascular or intercardiac pressure. So if it is down 3 inches, then this each inches is producing 2 mmHg pressure. So that is 6 mmHg pressure. So which is neutralized from the heart level. So positive hydrostatistics heads to the pressure that will be. So the transducer level will be that phlebostick levels below 3 inches, so that the pressure will come into the neutral phase. Then zeroing is performed by opening the system to the wear to establish the atmospheric pressure as 0, and referencing to accompanies by placing the air fluid interface of the catheter, means to the transducer, at the mid chest line. Then normal values of the pressure in cardiac chambers. The RA pressure, mean pressure we are taking 2 to 7 mmHg, LA pressure normally 5 to 8 mmHg, RV systolic pressure 25 to 30 mmHg, RV diastolic pressure 0. RV and diastolic pressure is equivalent to the RA mean pressure is 5 to 7 mmHg. PA systolic pressure 25 to 30 mmHg, PA diastolic pressure is 8 to 12 mmHg, and the aorta systolic pressure is 120 mmHg, aorta diastolic pressure 80 mmHg, LV systolic pressure 120, and LV diastolic pressure 0, and LV and diastolic pressure is equivalent to the LA mean pressure if there is no mitral valve stenosis. So here we see that the RV diastolic pressure and the LV diastolic pressure comes 0. Why the left ventricular diastolic pressure is 0? You see the right atrial mean pressure and the left atrial mean pressure is very low, means it's 2 to 7 the right atrial mean pressure, and left atrial mean pressure is 5 to 8. So we know that when the atrial systole is there, at that time there is a diastolic phase into the ventricle. That means the relaxation phase. So whenever the atria is contracting, at that time blood is coming through the tricuspid valve to mitral valve, from right atria to right ventricle and left atria to left ventricle. So if there is a diastolic pressure into the ventricle, then blood cannot come from atria to the ventricle. So that's why always right ventricle and left ventricular diastolic pressure is 0. But there is a end diastolic pressure. That end diastolic pressure, RV end diastolic pressure, is equivalent to the RA mean pressure, and the LV end diastolic pressure is equivalent to the LA mean pressure. So this is not that much important. There is a curve. This is the aortic pressure curve. You see this aortic pressure curve, whenever it's a, there are two stage X. One is anacretic limb and another it is diacrotic limb. Anacretic limbs means whenever the systole phase is going on, at that time the pressure is arises. And at that time, the peak systolic pressure, you see, there is a peak systolic pressure which is equivalent to the normal aortic pressure is 120 systolic pressure. And then it's come down to the diastolic phase. And then in between, there is a diacrotic notch. You see, there is a diacrotic notch. This diacrotic notch means, I will tell later on. So, and here you see that there is a two peak pressure. One is systolic pressure, and another one is the diastolic pressure. In between there is the systolic upstroke, and then there is the sorry, my marker is not working. Anyway, so this is the systolic notch, and there is the diastolic, means end diastolic pressure. The lower one is the end diastolic pressure, so which is 120 and 80. Sorry, I'm skipping some slides because I want to show here. This slide is very important. So here you see when the systolic is rising up, at that time, that point where the arrow marks is there, the aortic valves are open. And when there is a diacrotic notch in that area, the aortic valve is closing. So in this area, when the aortic valves open, the systolic pressure are going up, because at that time there is a ventricular systolic pressure. Systole is going on. So at that time, blood will go from aortic from the left ventricle, it will go to aorta, and from the right ventricle, it goes to the pulmonary artery. So at that time, the aortic valves are opening. And when the diastolic phase is coming down, and in the diacrotic notch, there will be aortic valve closing. Here I will show the pressure curve. Here is the RA waveform. This RA waveform normal value is 0 to 8 mmHg, and RA pressure is equivalent to the CVP pressure. The wave fluctuation due to the contraction means the down one is the upper one is the ECG, and down one is the right atrial waveform. This is RV waveform, and you see in the background there is a Swan-Ganz catheter. In a background, there is a Swan-Ganz catheter. The Swan-Ganz catheter is coming from the right atria, means from the down, means from the IVC, it's coming to the right atria, and from right atria, it goes to the right ventricle. And in this area, I'm showing here the right ventricular systolic pressure, and this one is the right ventricular end diastolic pressure. The right ventricular normal pressure is 15 to 25, and the end diastolic pressure is around 5 to 8 mmHg. This is PA wave from the normal value, means normal PA systolic pressure is 15 to 25 and the diastolic pressure is 8 to 15. Diacritic notch, same as in the PA atrial pressure, there is a diacritic notch. It represents the pulmonic valve closure. So PA diastolic pressure approximates a PA WP pressure, means pulmonary artery wedge pressure, which is equivalent to the LV end diastolic pressure if there is no mitral valve disease. This is PAWP pressure. This is Swan-Ganz catheter. You are seeing it goes one of the pulmonary artery branches, and there we can see the PA pressure, and this PA pressure is equivalent to the left atrial pressure. PAWP means pulmonary artery wedge pressure is equivalent to the LA pressure. This is A indicates is the RA waveform, B indicates the RV waveform, C indicates the PA waveform, and D is indicating PAWP pressure, means pulmonary artery wedge pressure. And here you see there is a LV systolic pressure and LV end diastolic pressure. And if there is a, in this slide, I want to show the aortic valve disease. So here you see the aorta pressure. The blue color is aorta pressure and purple color is left ventricular pressure. And from aorta systolic to LV systolic, there is a gradient of 47. And this is aortic valve stenosis. So LV systolic pressure will go high because of aortic valve is not opening properly. So from the other side, LV will get proper blood supply, but from the LV, due to aortic valve stenosis, blood will not go to the aorta properly. So the LV systolic pressure will go high, but the aorta systolic pressure will remain same. So difference between the aorta's LV systolic pressure and the aorta systolic pressure is the difference across the aortic valve. Here I have seen there is some ventricularization of pressure. The upper one where the notch is there, that is the proper aortic pressure. But the down one, the down curve, the shape of the arterial pressure curve is not sharp. You see there is some U shape. This pressure curve is little bit U shape. So this means there are some ventricularization. So when it's happened, if the left main, when the catheter is engaging into the left main ostia, if the catheter goes to the, if a patient left main is having some disease, then the curve will come like this, means that there will be some ventricularization of the pressure. Or sometimes maybe your catheter tip will touch to the superior border of the left main. So if it is there, then also there will be some ventricularization of the pressure you will find in your hemodynamic monitor. So whenever it will be happen, you have to immediately inform your consultant, means in the operator who is doing the procedure, that these are the thing. It may be ostia of the left main, or maybe ostia of the right coronary artery, or maybe the catheter is towards the superior border of the left main. So that time the operator will be careful. He will not give much forceful injection, or he will take out the catheter and trying to manage the pressure ventricularization. Here I have seen there are some catheter which is having into the right coronary artery, there is some ostial narrowing. So in that cases, you see in the right side, there will be some pressure curve. So these are the normal pressure we are seeing, the little bit U shape, means when the catheter is engaging into the left main ostia or in the right ostia, there are some disease. The normal pressure curve will change. It will not sharp like normal arterial pressure. It will be some U shape. So that is ventricularized. You have to be careful very much whenever you will get this type of pressure into your hemodynamic monitor. That already I discussed. This one also you already discussed. This one also I've shown. Well, this is a case where we are doing the PTMC, mitral valvuloplasty. That means patient is having some mitral valve disease, and we are opening the mitral valve. So in that cases, we have to see two simultaneously pressure. Normally what happens, PCWP pressure is equivalent to the left atrial pressure, is equivalent to the LV endostolic pressure if there is no mitral valve stenosis. But whenever the mitral valve stenosis is there, then from the pulmonary vein, blood will come normally to the left atria. But after coming the left atria, the blood will not go properly from left atria to the left ventricle through the mitral valve because of mitral valve stenosis. So what will happen at that time? The mitral valve, the left atria pressure will go high, left atria will be dilated, and left atria will be overloaded. You all have seen whenever a patient is having mitral valve stenosis, the LA will be the enlarged because of this reason, because from the pulmonary vein, the normal oxygenated blood is coming to the left atria normally, but after coming to the left atria, blood will not come from left atria to the left ventricle proper way because of mitral valve stenosis. So at that time, LA pressure will go high, LA will be enlarged, and LA will be overloaded. So here we are seeing the LA mean pressure, and here we are seeing the LV end diastolic pressure. So here LV end diastolic pressure is around 10, and the LA mean pressure is around 22, 23 like this. So difference between the LA mean pressure and LV end diastolic pressure is the gradient across the mitral valve. So here gradient is 13 mmHg. So this is the pre-procedure. Then after opening the mitral valve, you see the hemodynamic has changed. The LA mean pressure has come down to 10 or 12, and end diastolic pressure is 10. So gradient across the mitral valve is only 2. So this is acceptable mitral valvuloplasty. This I have already discussed. So complication. So invasive hemodynamic monitoring, there are some complication is there. Local destruction with distal ischemia. So whenever we are putting the Swan-Ganj catheter into the distal pulmonary artery, maybe there are some distal ischemia, external hemorrhage. It may happen due to the catheter tip or something like that. Then dissection also it can happen. Ear embolization is very common, and you have to very much careful for ear embolization, because in these cases anywhere some ear will go inside, then it may cause harm to the patient, little bit blood loss, pain, and arterial spasm and infection. So for this, we have to be very much careful for this complication. And here is a video where the blood flow is flowing into the heart. So this is all. If anybody is having any questions, feel free to ask me.
Thank you, Mr. Kaushik Datta, for your brilliant presentation. You have touched every possible points which should be taken care of in Cathlab, which will be very helpful for our Cathlab technician and nurses. Now, I'd like to request Professor Wadud Chaudhary sir to say a few words on your lecture. Wadud sir.
I think Kaushik has shown how to look at the waveforms at the monitor. You can have a look, but you have to understand what the waves are saying to you. From the coronaries, dumping, ventricularization, to the gradients across the valves, the aortic valve gradients or mitral valve gradients, whether after PTMC we have successfully done it, or if there is reduction in the gradient. All these things you can actually have a look at the waveform without even looking at the absolute values. You can have an idea whether you are in trouble or you have done a procedure very successfully. That's the essence of knowing what you are looking at. We have to have some idea about that. Thank you, Kaushik.
Thank you, sir. We are lucky enough to have Sophia Madam with us. Sophia Madam, please say a few words. Madam, do you hear me, sir? Sophia Madam? Please unmute.
Okay.
No, thank you. I'm not a panelist, but I'm just a guest always there all the time. Anyway, yeah, it was really nice to see, and it was an excellent presentation. And those are keen to learn, and there's a thing in the monitor is actually is a really essential. You see, when we are in the cath lab, we are not only working ourselves and thinking about only patient and myself. It's not like that. It's a teamwork, and a teamwork is so important that you cannot do anything alone. So your technician, your nurse, and then most of the centers, they don't keep the anesthetist, but I think wherever is possible, and it should be, the anesthetist should be there as well. There's so many anesthetists are there. If they make a roster to have a anesthetist in the cath lab, it's a blessing for the patient and for the team. No doubt about it, because once somebody, the anesthetist is there, you know that you will take care of the, if any emergency comes or anything happens to the patient, which anesthetist is required, because you cannot just leave the patient and then resuscitate on the other side. But if anesthetist there is a really good hand for you. So yeah, I still today, I don't do any case without an anesthetist. And this is a good practice, and a lot of the centers, even if you hear from those I have learned from my colleagues from India and abroad or everywhere, they keep their anesthetic standby. Number two is that the technicians are there, if you can always recognize who is intelligent, who is capable of doing, and who is helping you. So if when you are doing any procedure, they always mention the pressure is dropping, damping, the ventricle is somewhere else, the catheter, which is that is a great help. Even if sometimes you are absent-minded at that time, or you are not seen for some other reason, they are very good help. And what is lacking, I have seen till today, it's really, it gives me pain, and I really suffer with this thing, is that sterility maintaining in the cath lab is not at all satisfactory in any center. You cannot keep your hand in your heart and say, yes, it is done, because they right from wearing the gloves, preparing the table, preparing patient, and they're watching the monitor. So is most of the centers are lacking. So this is one thing. I know you presented so nice. You can see monitor, you can see the pressure wave, you can see the ECG, you can see everything there. You can even if you do a cine, you can see that also, and you can interpret it. There's a block here and there in any angle. which is suitable. But we are still in this century after all 30 years. It's a really pain that we don't have the proper sterility there. So I think, we should concentrate in that as well. And mainly in this, not only for this COVID era, COVID has come, COVID will go, but we have to take care of that thing as well. Because sometimes we do shortcuts, sometimes we use inflator in remote, from the remote to save the money. Sometimes these are all things everybody in India and here we know all this. So even in Nepal. So my thing is that keep the anesthetist while you are mainly your news center, you are running and you're coming up. That is very good thing to have. And next thing is that please, please, please try to make the sterility in that so that you as well as the patient as well as the operator, nobody is affected. That is my message for you.
Thank you,
Thank you.
madam. Thank you for bringing two important points, that is presence of anesthetist and the sterilization in the. So we should always be aware of these things. So as we have shortage of time, so and three presenters are still awaiting. In this situation, I am requesting Mr. Shanta Singh Thakuri, Shahid Gangalal Heart Center from Kathmundu, Nepal, to present her topic. Ms.
Yes,
Shanta
sir.
Singh Thakuri,
Yeah, I'm here. Thank you, sir.
please share slide.
Okay, I'm sharing. Is it visible, sir?
Yeah.
Once again, good evening, everybody. I am Shanta Singh Thakuri from Nepal. I am working at Gangalal National Heart Center in Cathlab department. First of all, I would like to thank IPDI for providing me this opportunity to be a part of this program. Today, I am going to present the role and responsibility of Cathlab nurse. Before starting my presentations, I would like to share a brief overview of our hospital. This is the picture of our hospital, which was established in 1995. It is one and only tertiary level cardiac center of Nepal. Our hospital had started Cathlab services from 2000 AD, which provides 24/7 hours emergency services. Now I am going to show the data of cardiac procedures which had been done in 2019. The total number of angiogram cases were 5,240, angioplasty 1,773, PTMC 329, TPI 449, PPI 391, CRT 8, CRTD 8, ICD 16, EPS RFA 287 2D and 27 3D, ASD 258, PDA 127, PSD 25, and RSCLC 61. Now I am going to on my topic. What is cardiac cath lab nurse? It means specialized in working with patients undergoing cardiac procedures in a cath lab. Especially all trained nurses assist the medical team in diagnostic as well as in interventional procedures and perform distinct roles in cath lab. In cath lab, there are various types of procedures are performed in daily basis, like coronary and peripheral angiogram and angioplasty, electrophysiological study and RFA, 3D mapping. In device, we do permanent pacemaker, CRT, ICD. In structural closure, we performed ASD, BSD, PDA closure procedures, and BPB, BAB also, PDA stenting, rotational arthrectomy, IVAS, FFR procedures. Our hospital provides provides cardiac care to the adult as well as pediatric cases. As the emergency procedure, we do primary PCI, temporary pacemaker implantation, insertion, pericardiocentesis, etc. For the primary PCI, door to wire crossing time should be 60 minutes. This protocol we have been following in our hospital. As a rescue procedure, we do rescue PCI, and all the scheduled cases has been done in elective cases, as elective procedures. Prior to patient arrival, what should we do in cath lab? First of all, we have to prepare the cath lab with the following items, like resuscitation trolley should be in ready position, and oxygen and suction equipment should be ready, and defibrillator should be checked. All the emergency drugs and other drugs should be there. IV fluids like hypotonic, isotonic, and hypotonic solution should be there. Emergency pacing equipments like TPI should be in ready condition, and watch for the general stocks like catheters, stent, guide wire, balloons, devices, etc. And check the imaging machines like IVUS, FFR, and OCT machine. Patient status. In the cath lab, patient may come with hemodynamically or electrically stable or unstable conditions, and she should watch the level of consciousness of the patient. Patient might be in conscious condition, semi-conscious condition, or unconscious condition. The care of patient. Nurse has to provide pre-procedure care, during procedure care, and post-procedure care. In pre-procedure care, she has to confirm about the patient details like name, age, sex, and types of procedures, and take relevant history regarding disease conditions, and take vital signs including ECG tracing, ECG, and she should review the medications like anticoagulant medications, anti-diabetic medications, anti-arrhythmic medications, and anti-diabetic medications. She should check the ECG and echo report, and all the investigations should be collected like SB, grouping, CBC, platelets, serology, blood sugar, RFT, LFT, and coagulation profile also should be there. Check consent and NPO status of the patient. Patient should be in NPO for at least 4 to 6 hours, and check the safety checklist, and take the history of allergies like contrast allergy or drugs allergy. IV line should be opened and provide psychological support to the patient. And exercise like radial or femoral. In our hospital, mostly we do procedure through radial approach. During the procedure, reassure and support the patients, and that may be awakened during the procedure. Administer medications as prescribed. During the procedure, she has to be a scrub nurse or as a floor nurse. Scrub nurse has to assist in procedures, and floor nurse has to administer medications and supply sterile equipment to the scrub nurse. In detail, as a scrub nurse, she has to prepare sterile trolley for appropriate equipment with appropriate equipments, and maintain sterile field to prevent cross-infection. Ensure all the catheters are flushed with ephemerized saline to prevent clots and air embolism. Assist operator ensuring hospital protocols are adhered to. Safe disposal of saps and blood contaminated equipments, and monitor patient's vital sign. As a circulating nurse, she should supply the sterile equipments to the scrub nurse and monitor patient's vital sign, including ECG tracing. She should watch ECG at any time. ECG changes can be present if such as ventricular tachycardia, ventricular fibrillation, if and this kind of ECG appear, then she should inform the operator, and she has to manage accordingly. Documentation of equipment which are used in procedure and record of administered drug. Was for any complications during procedures. Monitor contrast limit to administer fluid if necessary. The contrast limit is 3 to 5 ml per kg body weight. If more than that, and we should inform the operator, and administer fluid is ordered. Monitor blood glucose level. If the patient is diabetic patient, then we should monitor the blood glucose level and monitor patient's verbal and non-verbal sign of pain and discomfort. Maintain patient's dignity and privacy every time. In the cath lab, at any time, any emergency, any medical emergency may arise. So nurse should have the ability to do CPR or assist in intubation or assist in medical team and manage the complication. After the procedure, the nurse has to access puncture site like radial and femoral for the any complications like bleeding or hematoma, monitor vital signs, and check the conscious level of the patients. If patient did not get any sedation, then patient should be in conscious condition. If the patient got conscious sedations like low dose midazolam or fentanyl, then patient might be in drowsy condition. So that's why nurse has to assess the consciousness of the patient. Check the dorsalis pedis pulse for arterial perfusion. And after the procedure, nurse has to transfer the patient to the appropriate ward or CCU. And she has to check the any complications like chest pain or shortness of breath. If this sign occurred, then she has to inform the operator and administer medicines like morphine, GTN, and other medicines as ordered by the operator. Complications. At in time, complication may occur during the procedures. Complications like hematoma, bleeding, stroke, dysrhythmias like VTVF, vascular injury, allergic reactions, pulmonary edema, ear or clot embolism, vasovagal reaction, even death may occur during the procedure. So she has to access this complication and manage accordingly. Another important role of nurses in sterilization in cath lab is sterilizations. Sterilization is very important in cath lab to prevent infection and lower the cost of cath lab. Though there is a risk of infection and possibility of catheter break, most of the developing countries like Nepal reuse the catheters, but not reused by the developed countries. How we sterilize in our hospital. First of all, after finishing the cases, we should clean all the cath lab tools with cath lab goods with water and disinfect with broad spectrum biocides like chlorosept and send them for autoclave. In the cath lab, we can't do all the instrument autoclave, so that's why we should do chemical sterilizations like ethylene oxide sterilization. It is the most it is one of the most reliable sterilized procedure of sterilization, and we can sterilize with glutaraldehyde and paraformaldehyde. Now I'm going to show you what we did in COVID era in our cath lab. Altogether we have 4 cath labs. 3 are running and 1 is replacing by new one, which is under constructions. At the time, at the peak of COVID, we separated one Cathlab for COVID and emergency procedures and others for the non-COVID patients. And our hospital admin provide sufficient PPE for the healthcare provider, and all the healthcare provider and healthcare provider follow the hospital protocol and guidelines. And at the time, all the experienced operator performed procedures to minimize the exposure. Like this way, we did procedure at that time. In conclusion, cardiac cath lab nurse is a specialized in working with patients undergoing cardiac procedures. The role of cardiac cath lab nurse is to assist with catheterization and monitor and examine patients prior to procedure, during and after the procedures, and prepare the cath lab to receive the patient. Administer medications as ordered as needed, and tackle any medical emergencies, and assist the medical team in whatever they may need during the procedure. Watch for general stocks of emergency medicines and other devices like stent, balloon, and other catheters. And ensure the sterilization of cath goods, example, catheters and wire, etc. Thank you. I'm going to wrap up my presentation with the Florence Nightingale, the Lady with the Lamp. Thank you.
Thank you, Mrs. Shanta. Thank you for
everyone.
your brilliant presentation. You covered everything possible in this short period. I think our all cath lab nurses and technicians will be helpful from your lectures. Thank you, and wish to hear from you next. In this condition, I'd like to request Dr. Arun Maski sir to say a few words. Arun Maski sir.
Thank you, Shanta. You have given a brief overview and excellent presentation. Our presentation is as good as the way she works in cath lab. We have in charge, cath lab in charge, Kopila Lutel here, and Shanta's sister is co-in charge, and they do a wonderful job. And her presentation is as her work she does in cath lab. Thank you for presenting in a nice, short way and concise way. That was a brilliant presentation.
Thank you, sir. Thanks a lot. I'd like to request Kopila Luitel to say a few words. Ms. Kopila Luitel, please unmute.
Good evening, everybody. But first of all, I would like to thank IPDI to participate, to be a part in this program to our center. Shanta, she has a nice presentation. It will helpful for the nurses to work in cath lab. Thank you, everybody, and thank you, sir, to be a part of this program.
Thank you, Ms. Kopila. And I would like to request Professor Amal sir to say a few words. Amal sir.
Thank you. It's my privilege to give opportunity to tell something about the cath lab nurses and technician. I have heard both the presentation from India and Nepal. Arun Maski's institute is very brilliant and very needful. The nurse is the mainstay, and technician is the mainstay of the cath lab. We goes and frequently goes and out from the cath lab, but they are the board of the cath lab. So she has rightly mentioned that the sterility, about the how to sterile, how to circulate the essential things, how to hemodynamic monitors from India and Birla hospital cath lab technician very nicely told. I cannot mention his name, so thank you, Arif, for
thank you, sir. Thank you, sir. We have two brilliant lecturers for presenting their topics. I would like to request Mr. Farhad Hossain to deliver his speech. Mr. Farhad Hossain, who is from Midford Hospital. Mr. Farhad, do you hear me?
Yeah.
Yes, please share your screen.
Assalamu alaikum and good evening. Welcome to IPDI Cathlab Technician Refresher Course 2020 Series 2. PTMC, role of technician. I am Farhad Hossain, Senior Cathlab Technician, Sir Solimullah Medical College and Mitford Hospital. Here is Dr. Inoy, sir. He is the father of PTMC balloon catheter. Background. Percutaneous transvenous mitral commissurotomy is indicated for patients with symptomatic severe mitral stenosis. Patient's history, clinical examination, and baseline investigation are mandatory before procedure. Absolute and relative contraindication are to be excluded beforehand: LA thrombus, severely calcified commissure, unsuitable interanterior septum, etc. Catheter or instrument for PTMC. For septal puncture, Mullin sheet, broken bone needle, three-way stopcock with saline and contrast, femoral access sheet, 6 French and 8 French, septal dilator, 14 French, spring wire, Inoy balloon, LV entry stylet shaper, pigtail catheter, terimoire. This is all things. Inoy balloon catheter and auxiliary instruments. First, we talk to patient about PTMC and oil scarring and drafting. And then we local anesthesia, right femoral side. This is two vascular access sheets, 6 French and 8 French. 6 French are using artery and 8 French as venous. First time we punctured venous side, and secondly punctured artery side. Those sides are punctured finished. Then we put two vascular access sheet. First artery access sheet and then 8 French is venous access sheet. Pigtail catheter, we go pigtail catheter aorta and then connecting aortic pressure. And aortic pressure is now 111 and 90 on 102. Inoy balloon. Inoy balloon has 3 port. 1 port is vent and another port is main. The balloon is composed of the 3 layers. There is an outer latex layer, an intermediate mesh layer, and an inner latex layer. The mesh regulates maximum diameter and inner pressure of the balloon. Mesh breakage may be caused by overinflation of the balloon past the acceptable inner balloon pressure. Rapid increase of inner pressure that may occur when the balloon is inflating in a heavily calcified mitral valve. Do not exceed the maximum recommended inflation volume made on the syringe provided with the Inoy balloon catheter. Inject dilated contrast medium slowly to inflate the balloon during the test inflation in order to avoid rapid stressing of the mesh layer. Balloon sizing. Balloon dilating diameter is equal to height of patient in cm divided 10 plus 10. Example, on patient height is 160 centimeter divided 10 plus 10 is equal to 26 mm balloon. Measuring the size of the balloon. Figure sizing of the Inoy balloon. Figure A, graduate students for choosing the appropriate balloon size. This may vary by 4 mm for each balloon. The diameter of the balloon inflation should be measured before inserting the balloon. Terimoire, mulin sheet with broken bro needle. First time we mulin sheet with terimoire goes for SBC, and terimoire withdraw broken bro needle. The distal curve corresponds to the direction of the arrow at the hub. Broken bro needle with no dilatation contrast. Broken bro needle inside the mulin sheet and pull slowly. Left panel schematic illustration of withdrawing the catheter needle assembly from the superior vena cava to the fossa ovalis implant plant, pathological showing fossa ovalis with the syndromic edge. AP view, we see AP view and lateral view. Figure A, invoice method using contract RA and LA. Figure B, Hang's method using fluoroscopy. Hang's method, AP view, lateral view. When we sure that this is fossa ovalis, then we septogram. And when puncture, and allography, after allography, showing the LA pressure, now LA pressure 48, 13 and 27. And spring wire put LA and H French exercise sheet withdraw and septal dilator 14 French septal dilator septum the dilate and spring over the spring wire. Sternite balloon strainer and put inside the balloon before strainer and after strainer, and going to balloon LA and LV entry stylet shaper goes to LA to LV. Yeah. Video, no? After ballooning, decrease of LA pressure by 50%. Now LA pressure is 23, 5 and 12. Before balloon, LA pressure was 48, 13 and 27. And connecting aortic pressure increasing. Now withdraw the balloon catheter. Take home message. Very complicated procedure, fully blind procedure, need combined team approach, stepwise regular exposure and training is needed for the perfection of procedure. Before ending the presentation, I want to pay my utmost respect to all the healthcare professionals, including physicians, nurses, lab technicians, and support staff from Bangladesh and all over the world who died during the COVID-19 pandemic serving the people. May Almighty Allah give them highest place in the heaven. Thank you, honorable audience, for Patience Hearing, thank Incepta and Boston Scientific. Thank you, everybody.
Thank you, Mr. Farhad, because you have very simply and meticulously described a very complex procedure. You know, where PTMC is very tough procedure, but you had make it very simple. Thanks a lot. We have the opportunity to meet Mr. Inouye, who invented the Mr. Inouye balloon, and Professor Abdul Rahman is the person who made this opportunity for all of us. After
Yes,
his
sir.
visit,
Yes, sir.
after his visit in our country, around 30 to 40 independent PTMC operators have been created, and they're doing independently outside. In this regard, I was
Thank
to
you,
hear from
Abdul
Abdul
Rahman,
Rahman sir. Sir, please say a few words. Abdul Rahman sir.
So, that the legend or the pioneer of the PTMC is come to Bangladesh and visit NSPT when I was the chair. And it is really honored for us and for all the doctors and especially the technician. So we have worked with him and we have gained a lot of experience with that. Though we are not follow exactly the same procedure that we are doing nowadays, but his technique is good. So thank you for your nice presentation, elaborate presentation.
Thank you, sir.
Thank you, sir. I would like to request Chaudhuri Meshkat sir to say a few words. Meshkat sir.
Thank you very much. It has been very enlightening session. I don't have any comment, but I have a question to Ms. Shanta. You have elaborately described all the responsibility of a nurse in a cath lab, but how is about radiation safety? What is the role of cardiac nurses in cath lab as regard radiation safety? Radiation safety in part of the nurses themselves and the other staff who works in the cath lab. This can be an important issue which can be looked after by the nurses. The presentation has been really excellent. All the three presenters has presented their cases in a very nice way, especially the first speaker who elaborately has shown us the importance of measuring the pressures and the oximeters, which is so much important. In our initial days, Professor Sufia was our sole interventional cardiologist at that time. She used to say that it's almost like flying a aircraft. And if it is a aircraft, then you need the ground engineer and on the craft. So it is all the way aircraft, a journey like that. We have to start it safely and we have to land it safely. And everybody. Thank you.
Thank you, sir.
Shanta is here.
Oh, Santa's connection is lost. So
I think most important part is asked by Professor Chaudhuri because it is most neglected in our country also. So our technician cath lab is whole time present in the cath lab, but I think they are neglected so much. Dr. Urmaski,
Santa's connection is lost. So our radiation part is done by radiographers. So if you want this, I can ask one of our radiographer. He's ready to present in next session about radiation safety.
Now, Dr. Urmaski, how you protect yourself in the cath labs in the radiation? Any radiation badge in your cath lab?
Yeah, we have a radiation badge. We have radiation badge. We use two radiation stuff, one jacket and one skirt, and then we have a lead seal, and we monthly monitor. At least 2 to 3 months, we have a radiation seal and we monitor radiations.
You are so much lucky because Bangladesh is so much neglected this part. We have no batch in Bangladesh. I am asking last 2 years fighting for that, but nobody is here.
This is not. We don't have batch here.
We are so unlucky in Bangladesh. We are cath lab staffs, nurse, operator doing no radiation safety in Bangladesh. We're sorry to say.
What we do is we have connected with some India, I think Birla Institute, I think.
Excellent.
So they send the batch and we send batch from here and monitor.
Excellent. But we are sorry to say we have no any other radiation. I think Professor Subirawan, Madam, is low experience in the cath lab, but we are sorry to say we have no radiation protection in Bangladesh. We are sorry to say, but we are fighting for last 2 years. In this regards.
I say something.
Yes, sir. Yes, madam.
In this regard, don't say we didn't have, we had. We had in my time in NICVD, we had the badge where they from the atomic energy we got them, and first time they have taken back, and then the third lot they have done. After that, because of the payment sake, it was not continued. When I joined the private sector like Eurobangla Hospital, they also had these badges here. And that also, after 2 years, nobody encouraged or it didn't work out. So I think it's not difficult motion. Is I know you have to really put your foot down, and the best thing is to talk to the atomic energy. You go and make an appointment, which I did, then you will get it. If you sit down for your director to do it, it will not be done, because most of the now your director is also interventionist, so it probably he will encourage you a lot. And you have to make an appointment, go there, make them understand how vulnerable situation you are, and you are doing the job. They might come to your table one day, all these blah 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 you have to tell, and make sure frighten them a bit and request them a bit. You will get it. We had it. It's not that we didn't have it. We did have it, but we couldn't continue this. The presentation was excellent, all of them, and I really liked it. For you see, one other thing is that what from Nepal, is it Shanta, na? She said, but you see, most of the time, what we do, you said, even from India said, even for others said, but one thing is lacking. You see, all of us in a team, when we select a patient as a physician, we do explain. But when they go to the real place, it's like swimming, if you tell that you have to go to the water, you have to do your hands like that, legs like that, then you have to float. It is easy to say, but it is difficult to do. So like that, each and every one in the cath lab has got the responsibility to make sure the patient understand what is going on. And believe me, it really matters for the nurses first when the patient is in the cath lab, and then the technicians. You have to reassure and reassure and reassure, because most of the complication, out of the fear will go. And this is really from our team. As a physician, we explain, but when they lie down in the table, seeing a huge machine in the top of their body, so you have to say a lot of words like, don't worry about the machine, it will not fall on you, it will rotate on both sides of you, we are here for you, things like that. I know you all know it, but each and every patient, even they're a physician, they also get frightened. So there is a role, since it is a cath lab issue, and there's a cath lab training part. This is really, really important that you reassure and reassure from each one of them. And when the patient is female, and then make sure the nurses are more in front than the others. That also makes a difference. No matter which country you are, most of our country in India, they are more shy about it. This
Thank
is
you.
Thank you. Thank you, madam.
very, very important that, when the sister goes and says, look, I'm cleaning your part and I'm going to do it. There is no man is there. This is, social thing. Don't worry about that. I know you know it, but just because you are the senior, you probably know, your junior should know. One other thing is that when the patient comes in the cath lab, all should be it's like a harmony. One, two, three, four. Your doctor is ready, your technician is ready, your nurse is ready, and then so let's go. Let's drive the car. So this should be the tempo of the cath lab where you are looking at the patient. Another other thing is that from Nepal, they are saying, don't worry about the reuse thing. We learned it from the West. When the West came, did it, I was there. I know we have reused it in there also. So we learn it from them, but they are rich now, they can afford it. So they're doing it. We cannot afford it, so we'll continue to do that. That's not the thing. But what we are doing, how we are doing sterilization is really, really depends on the nurse and the technician, not the physician. unfortunately. But fortunately is that this is your job to clean it nicely, to gas it nicely, to soak it nicely, then put it on the table nicely. These are your part. So don't worry about that. As long one day we'll be also reach and throw this thing away, no doubt about it. But till then, because our patient is poor, we have to sometimes do this procedure absolutely free, or sometimes with a very nominal charge. So this thing nobody else in the world is doing, so they can afford to do that. So don't worry about it, don't feel bad. As long as you really re-sterilize it nicely, so there is nothing left. Thank you very much.
Thank you, madam. Thank you. Thank you for your experience. Only health insurance can provide the new device. We have to wait until health insurance covers.
No, but two things. You see, when we used the catheter, it was 16, 1700. Now it's 600.
Yeah.
So when it will be 300, we can throw it. We will not have to,
thank you.
because the reagent and the machine will cost more. So let it be, let's pray for 300. And the catheter we used to reuse, they were really tough and rough. But these days you can hardly use it. Even the wire, even the balloon,
Exactly.
they are not that strong as they used to be. So the manufacturer has come down with this. So we will also come down. And when it will, the wire is now 6,000 something. But you see, if when we were there 18, 20 plus like that. One other thing is that because you are presented with the PTMC, but we did also metallic procedure as well. At that time it was easy because metallic thing you can sterilize very nicely rather than the plastic thing. Anyway, that is another chapter. I'm sure Wadud and Mohsin, they're doing brilliantly this thing. So they will do it in future. And also organizers behind the scene and in front of the scene, everybody, thank you. And this is my opportunity to see you all. We are mainly Arun Maski, after a long time seeing him again. Thank you very much.
Thank you, ma'am.
Thank you, madam. Thanks a lot. A brilliant, sir.
Arif, one of the participants who is Zakir Hossain from India, I asked a question. Professor, Mr. Zakir Hossain, do you hear me? Syed Zakir Hossain? Mr. Zakir Hossain is waiting for his question. Okay, Professor Wadud sir, Abdul Wadud sir. Professor Abdul Wadud Choudhury sir, do you hear me, sir?
Yeah, I was just in and out because of the net problem.
Yeah.
So now we're using my mobile hotspot.
Exactly.
I think the beautiful presentation by Farhad has shown how we can do APTMC very safely. One thing during PTMC we have to remember, as he has mentioned, it's a blind procedure. You have to be sure you are puncturing the interictal septum in the proper place. And also, when you are dilating the balloon, inflating the balloon, it's better to do that once and quickly and properly, because doing it twice sometimes often leads to more injury to the vessel and more chances of mitral regurgitation. That we have to remember. And the issue of reusing the material and the chance of infective endocarditis is a reality that we have to bear in mind. We have seen many cases from many centers. Those were coming to Dhaka Medical College because it's a multi-center, multi-specialty hospital. So we have seen a lot of cases getting infective endocarditis post-PTMC. So all the operators and the Cathlab nurses and technicians who are responsible for maintaining the sterility of the materials which we are reusing, it cannot be overemphasized. They have to pay attention to it in very fine detail. Otherwise, a patient's life will be in danger. I think we have to wait for the next lecture, isn't it?
Yeah, exactly, sir. We have a brilliant presenter still waiting to present his excellent topic. There is Mr. Nazrul Islam from NICBD. He is doing in electrophysiology and pace lab. Mr. Nazrul Islam.
Yes, sir. Good evening, everyone. Assalamu alaikum. I am Mohammad Nazrul Islam, electrophysiology technician, National Institute of Cardiovascular Disease, NICVD, Dhaka, Bangladesh. Today, my presentation is pacemaker implantation, role of Cathlab technician. Implantable device. This one, single chamber pacemaker, this one, dual chamber pacemaker. Implantable device, pacemaker, ICD and CRT. Pacemaker for bradycardia, ICD for ventricular tachycardia, CRT for severe heart failure. Implantation activities. Now patient. Blood pressure, cough, coronary status, review reports, viral marker, blood group, creatinine, patient consent. Pre-implantation activities. Fasting, ECG setup, name entry, cannula, fluoroscopy, skin preparation, done physician, defibrillator plates. Pre-implantation activities, ECG, lead 1, 2, and B1, oximetry, defibrillator, intubation set, patient comfort. NIBP and connect ECG, human body, pulse oximetry and cannula. NIBP and oximeter monitor. This is image cover. TPM placement and generator connect. Implantation procedure. Preparation or approach, incision or puncture, dissection, pocket creation, lead placement and fixation, bone closure. Is this done physician? Cover the patient. Procedure approach, pectoral, right side or left side. Venous access, cephalic vein, advance, no pneumothorax, no crash. Dissection, cut down. Supply vein, fast, high success rate. Dissection, lead crash, pneumothorax. Axillary vein, fast, no crash. Dissection, need for venogram. This is still picture venogram, PVO. Supplement puncture. Supplement puncture, both axillary vein puncture, technique, 10 to 20 bolts of semi-dilate contrast puncture during venogram. Cephalic vein puncture, permanent lead placement, venogram, run, puncture, create the pocket, this incision, and pocket. Lead placement. This is AP view, also AP view. See? See? RA to cross RB and go to MTA, AP view. Both are AP view. 0, 0 degree AP view. This is AP view, RB apex lead placement and screw lead. AP view. Lateral view RB. This is TPM lead. This one is permanent pacemaker lead. Lateral view, 90 degree left lateral. This is RB septal lead placement and screw lead. This is 50 degree angle LO. RA lead placement, AP view, TPM remove AP view, এবং সতর্ক থাকতে হবে এই টাইমে যে আমাদের লিডটা যেন টিপিএম লিডটা আরবি লিডের সাথে যেন না লেগে বের হয়ে আসে, আরবি লিড ডিসপ্লেস না হয়। Single chamber pacemaker, this one single chamber pacemaker, this one is dual chamber pacemaker. Also this one AP view, this one is also AP view. Pacemaker complication, acute pneumothorax, air embolism, cardiac perforation and tamponade, coronary sinus dissection. We see this time oximetry down and pressure down, patient শ্বাস প্রশ্বাসের সমস্যা হবে, তার মানে তার এই টাইমে হাই ভলিউম অক্সিজেন দিতে হবে। থ্যাংক ইউ ফর
Thank you, Mr. Nazrul Islam, for your nice brilliant presentation. We have in Bangladesh we have around 100 Cathlabs, so lots of operators doing lots of procedure around Bangladesh. So we are operators are really comfortable with really expert Cathlab technician and nurses. Professor Athari sir, do you hear me, sir? You are the expert or device implementation.
Yes, Mohsen, I can hear you. Yes, Mohsen.
Sir, yes, sir.
Thank you, Mohsen, for inviting me, and thank you all the speakers, and finally, Mr. Nazrul Islam for your excellent and nice presentation. We know that the technicians are technically very experienced because they work every day, work with multiple operators, has got scope to see all types of complication. Nazrul is such a type of operator, that is the technician. He has wide experience of working almost in most of the Cathlabs in Bangladesh, and most of the operators of the Bangladesh such an experience. And I work almost 2 or 3 days with Mr. Nazrul, and he has got an X-ray eye. He can see that he helps us in such a way. When you do the venous puncture SC, he can see the veins. He asked me, sir, this is the direction of the vein. You just put here. This is the direction of the vein. He's such a technically sound technician. So this is the message what a technician should know. How much a technician should know, and how much a technician should help the operator. Sometimes in a puzzle situation like the perforation, I have many of the experience. That is inside the perforation. He is very expert to help the whole team. doing some assistance, need the patient temporary pacemaker. So these are the some of the parts of the technicians what the particularly technician like who are helps in during the procedures like device implantation, ICD, CR2 or like this. So this is the role of the technician, what we should know. And Nazrul Islam is one of the example, an ideal example, and he has got a wide experience of helping our team. So thank you, Nazrul Islam, for a brilliant presentation, and thanks the IPDI for inviting me for to attend such a type of excellent program. Thank you, Mohsin.
Thank you, sir. Thank you, sir. Dr. Mohsin Hossain, here, Professor Mohsin Hossain.
Assalamu alaikum. Thank you for inviting me. Thank you, Mr. Nazrul Islam, for your nice and brilliant presentation. Sir already has said he has a lot of experience with a lot of operators and he knows how to help the operator. I just say one example. When me and Nazrul in 2018 in Wuhan, China, doing observing cases in 3D complex case, and one operator is doing the complex procedure under general anesthesia, anesthesia was there, he's doing the complex procedure, and patient is sinking, but we and the operator is not seeing, but he just look, the patient is sinking, blood pressure coming down, oximeter is coming down, he just show us. And these Chinese doctor is wonder how the technician, he could observe the and he saved the life of the patient. So this is the Nazrul, sir telling he has every quality. And so I congratulate him. I thank you, Nazrul, for your brilliant presentation. Thank you.
Thank you. I just tell before, we operator are really comfortable when the expert technician with us. Dr. Kaushik Datta. Dr. Kaushik Datta, do you hear me?
Yes, yes.
Yes, Dr. Kaushik Datta.
Thank you.
You have also expert operator in foundation. Yeah.
Thank you, IPDI, for inviting me for my comment. Actually, this is a very helpful session, not only for the technician, but also for the operators, for the nurses. Many times, lot of things and many things I have learned from the technicians. I know Nazrul very personally, and he's very much expert and very much helpful. And if you don't have a good support, and when your team is on things, sometimes that day, Pujila ma'am was telling how you work. When your team is better than, when your team support is excellent, then the operator remain very much relaxed and do very complicated case also. So Nazrul is such a person. Already Atar sir and Dr. Mohsin told me, and I have learned from all the speakers a lot of things. And every day I am learning, not only from my seniors, from my colleagues, and especially from my the technicians and nurses, because they are observing a lot of cases. Multiple operators, multiple case. We are doing 5 or 6 cases, but they are attending all the 50 cases. So thank you, IPDI, once again for nice session. Thank you, Dr. Mohsin.
Thank you, Dr. Khondok Asaduzzaman. Do you hear me? Dr. Khondok Asaduzzaman. Khondok Asaduzzaman. I think he is disconnected now. Okay. I think Professor Abdul Wahid Chudri, Professor Abdul Wahid Chudri, sir. I think it is not ending of this program. I think it's continue technician course furthermore. I am requesting all the participants, please drop your cases or lecture in IPDI office from the Bangladesh, Nepal, or also India. We'll continue the program with your cases, interesting case, or any lectures. I think we hope we'll continue our series. Professor Abdul Wahid Chudri, sir, please.
What I will be suggesting that our eminent expert technicians, they collect some complicated cases, shows an example what can go wrong, then show how they have overcome that problem or may not be able to overcome that problem. because these examples of what can go wrong, that patient may have that problem. We want that none of our future patients have similar problem. And if even they have it, we can overcome that very quickly because we know how to overcome that. That will be how all of you can contribute. There's from Kaushik to Shanta to Farhad and Nazrul. All of you, I will ask all of you to do that. And also our eminent panelists, please show some complications where actually simple oversight of not looking for a particular, we have not paid attention to a particular hemodynamic data or something like that, that can lead to a problem. For example, in PTMC, we have seen PTMC where there has been RA perforation. We have seen where after the balloon dilatation, there is RP perforation, RP rupture, mitral valve tear. All these things, why that has happened, we should analyze that. And if we show those examples, our young stars, the young operators who will be the future of cardiology, interventional cardiology in this country, they'll be tremendously benefited. And also the technicians who are working in so many cath labs in the country, they will have the experience and come to know what can go wrong, how to look for that, how to identify that very quickly, and how to overcome that. Today's lectures were very informative. I want some examples with problems that can be shown in future lectures. So we'll be benefiting again from these experienced technicians. Thank you again.
I have a question to Dr. Urmaski. How will you continue your program technician course or cath lab nurse course in Nepal? Any registered organization or body keep them diploma course, anything in Nepal?
Cath lab technician, I'm not very aware.
Technician or nurse courses diploma?
No, we have a cath lab technician. I have
any course or any.
I don't
Mrs.
think we
Kopila
have
can
any
tell you about the.
Kopila or Shanta can talk. Shanta,
Kopila?
you are here?
Shanta,
Kopila?
please.
Kopila is there.
Any course or diploma course, anything course? Kopila, do you hear me?
Kopila, can you unmute? Oh yeah.
Any technician course or any technician course in Nepal? Registered course that is.
There is no any special course, but in our curriculum, some portion is about cath lab, coronary, like cardiovascular problems. There is some procedures and cath lab related procedures. We have to we can read the in program, but not a special course.
I don't think we have a cath technician course in Nepal, I think. No course, because I
There is
find
no any special course for cath lab technicians, I think.
What actually Mohsin emphasizing that
I raising this question because
Heart Foundation, only Heart
only Heart Foundation, yes.
What we do is radiographers are there, they go to cath lab, they get trained and they become a cath lab technician. So we, as such, there's no cath lab course, technician course in Nepal.
In Bangladesh, we have the more than 100 cath labs now, lots of operators doing, but unfortunately, Bangladesh only one course in the Heart Foundation. But I think Professor Wadudsa, others, such women here, we will try to do any course curriculum for the cath lab technician nurse. Wadudsa, please comments in about, or Mishkat sir can be comments regarding the issue. Professor Mishkat, because you need the registered course for the cath lab nurse and technician.
This is very important. Thank you, Mohsin, for
Mohsin, can I talk
yes,
about this?
Yes.
Fate of this course even then entry, first it was declared that the age limit was not there due to entry of some senior Cathlab technician, and then it is the science SSC the GPA 3 points. There, no,
Thank you, sir.
the curriculum
Professor,
certificate course 1 year.
The other research, do you any comment? Because it is the most important issue in Bangladesh. Because
whether the certificate will be taken from the state faculties or from the universities, and what will be the that is the examination criteria. These are some unsettled issues, and we did not know what happened after that. But it is still, I think that the file is still even in the NHB and the somewhere else. It is everything done. Actually, we tried to. It is about several years back, but the initiative was taken, and the Heart Foundation took the initiative after we did. And they have started, but we didn't actually finalize.
স্যার আমি বাংলাতে বলি আতার আলী স্যার, আমি মজুমদার স্যার এবং স্টেট ফ্যাকাল্টি দুজন মেম্বার স্যার, আমরা ইয়েতে আমাদের কনফারেন্স রুমে মিটিং করছি না স্যার কয়েকবার, এবং আমাকে বলা হয়েছে যে তুমি তো ডাক্তার বানাই দিচ্ছ, এত বড় সিলেবাস করছো। তারপর মজুমদার স্যার আমাকে অনেকবার ধমকও মারছে, যাই শর্ট করো। তারপর আমি শর্ট করেছি যে কনজেনিটাল হার্ট ডিজিজ কতটুকু জানতে হবে, ভালভুলার হার্ট ডিজিজ কতটুকু সব করা আছে।
জিনিসটা কিন্তু এখনো তৈরি আছে, তোমরা চাইলে ইনিশিয়েটিভ নিতে পারো। এবং স্টেট ফ্যাকাল্টি, আমি পরে যেটা বলছি, ইট ইজ জাস্ট স্টেট ফ্যাকাল্টি
from the Bangamundu University, Professor Jyoti Meshkar sir. Why not in the course in the
we have different perspective from the point of university, medical university. We actually, the supporting system in cardiovascular system is so important nowadays, not only in Cathlab, but also in the echo lab and other things. We had a plan. We talked about the a course which is just not merely a technician course. It is going to be a BSc in application science, so that they do very responsible jobs, so they have some honor and they have some basic knowledge, so that they get the BSc degree and they can do this job very honorfully. At the same note, I also want to mention that especially in the United Kingdom and in other European countries, they have MSc in cardiac nurses. So these are the people whom we can give some honor, we can dignify them, and they are really involved in so important job, as we all know that their contribution in the cath lab and in the echo lab has been so phenomenal over the years. So we have a plan. Probably we can introduce a course technician, not technician course, but it will be termed as BSc in application science, so that they are employed in a
one of the co-chairman, take an initiative to the Legal University to initiate the BSc science for the technicians and Cathlab nurses.
Yeah, assalamu alaikum. Good evening to was a bit late and for that personal commitment. Yes, this is a very burning issue. There are so many cath labs and there is no trained operator. Today morning, when I was telling my cath lab staff to attend this meeting, some of them said that, sir, can we do any courses? And if possible, we want to cover it up, because somebody is a bit older and they want to cover it up now. They want to know the knowledge. So I think that this course should be started other places, both in government and also private level. And IPDI should take an initiative, and it will definitely enrich our staff for interventions, both Cathlab nurse and Cathlab, technicians. And they will be trained, they will be educated They will know what they are doing. And I think if they are educated and they get a certificate, they will be well paid and have a good job perspective and job future as well. So I will request IPDI as well. I was thinking about this for a long time, and I shared this thought with many of our colleagues that we should work now on this field. কারণ ইন্টারভিউ কার্ডগুলো একটা লেভেলে চলে গেছে, হ্যাঁ, এখন 90% we've achieved, 10% বাকি আছে। এখন আমাদের সময় আসছে আমাদের নার্সদেরকে ট্রেন করার, যাতে ওরা কেরালা বা থাইল্যান্ড এই নার্সের লেভেলে হয়, আমাদের টেকনিশিয়ান ট্রেন করা, যাতে তারা ওই লেভেলে চলে যায়। তাহলে টিম ওয়ার্ক হবে। একা এখানে গোল দেওয়ার কোনো স্কোপ নাই, এখানে একটা সম্মিলিত টিম নিয়ে করতে হবে। এবং আমি মনে করি আইপিডি এর এই উদ্যোগটা নেওয়া উচিত। আমি আমাদের সম্মানিত চেয়ারম্যান প্রফেসর অদুল ভাইকেও বলবো এবং আমার ছোট ভাই মসজিদকে বলবো যে আমরা এই উদ্যোগটা নিতে পারি, এন্ড ইট ক্যান বি ডান। এটা না পারার কোনো কারণ নেই, ইনশাআল্লাহ।
Thank you, Kausik bhai. Thank you, everybody. I think thank you all the participants, all the brilliant speaker, Kaushik Datta, Shanta, also Nazrul, Farhad doing a tremendous job to prepare the session nicely. Professor Abdul sir, please conclude the session. I thank Inceptor Pharma and also Boston Scientific. Thanks both teamwork. Professor Abdul sir.
I think we have already, I have said enough, but just at this time, I just like to thank all the learned panelists who is here, from our mentor, Professor Sufia Rahman, to our colleagues, Atahar Bhai, Dr. Arun Maski, Mishkat Bhai, Kaisar Nasrullah Khan, Ashok Datto, Mohsin Hussain, Amalda, everybody is here. And thank you, everybody. And the technicians who are here and who are viewing these lectures, I hope this is of some benefit to you. Only then our endeavor will be successful. And in Inceptor Pharmaceuticals, we are really grateful to you for continuous support. Thank you, Mohsin. And Mohsin, your team, Shajol and you and everyone, thank you.
Thank you, sir. Thank you, sir. Stay safe, sir. Take care, sir.
Thank you very much, sir.
Thank you. Thank you, everybody.
Thank you. Thank you. Assalamu alaikum.
Assalamu alaikum.